Okay, so we're going to go ahead and kick off. We'll have a couple of people joining along the way, but we'll get started with our housekeeping. So first of all, I want to thank you all so much for joining us today for our first live panel since the COVID-19 crisis has changed a little bit the way we do things. So we used to do things called population health summits here at Cope Health Solutions, and we're very pleased today to have a population health summit-like panel with some of our colleagues. So I'm Alan Miller with Cope Health Solutions, and today's topic is how health plans are responding to the impact of COVID-19. We're going to talk about both long and short-term strategy, trends, lessons learned. So it should be a fun conversation. We scheduled it the day before the election, so you all could be very confident that all these lessons learned would be consistent and there'll be no changes tomorrow. Let's go to the next slide, please. All right, perfect. So I'm going to have Tom and Dr. Mohanty and Martha introduce themselves in a few moments, but we're really pleased to have with us Tom Meixner with Healthfirst, one of their senior executives dealing with a lot of different innovative projects, some of their network issues, finance, analytics, just a real champion of value-based payment with Healthfirst. We've got Dr. Sarita Mohanty, who is Vice President and one of the key leaders at Kaiser with relation to Medicaid, vulnerable populations, care management, impact of SDOH, and Martha Santana-Chin, who is the Government Programs Officer, meaning she oversees all of Medicare and Medicaid for Healthnet, which is the largest subsidiary of Centene. So a real key player also in the state of California. So very excited to have them with us. And again, after housekeeping, we'll have them introduce themselves in a little more detail. So next slide, please. So wanted to just talk through briefly so you all understand how this works. Again, it's not a webinar, so you'll see the PowerPoint disappear soon. We have some questions that have been submitted in advance already that we'll probably kick off with. You can also submit questions through the Q&A feature in Zoom, or you can email us at info@copehealthsolutions.com. We won't get through all the questions today based on what we've already received, but the good news is anything that you submit, we'll have a written Q&A that we'll send out after the panel, and we'll have, of course, a taped version of the panel as well. So with that, I'm going to ask Alice on our team to stop sharing. There we go. And we're going to get moving. So maybe we can start with introductions. So Martha, do you mind if we start with you?
Hey, Alan, it's Martha. First of all, my apologies, just my luck. I apparently have an unstable internet connection, so if I drop, I'll come back on. My apologies for that. So good afternoon, everyone, and thanks, Alan and team, for having us today. I am Martha Santana-Chin, Government Programs Officer for Healthnet. I've got responsibility for running our Medicare and our Medi-Cal businesses across the state of California. And I've been with Healthnet for about 7 years now. I've had a variety of different roles. Initially started working on standing up a program to really integrate benefits for our dually eligible population here in the state. In the majority of my career, I've actually worked on the provider side, both on working for a very large FQHC in California, as well as working for a large hospital system doing risk-based contracting. And just by way of background, just a little bit about Healthnet. Healthnet has been serving California for a little over 40 years. And we serve 3 million members of California, roughly 2 million of whom are covered by our Medi-Cal program, 150,000 by Medicare, and then the balance are covered by commercially insured products. And we have quite an extensive focus on Medi-Cal, long history with that program, and are very excited about the future and the challenges ahead of the opportunities that come with them. So thanks again for having me.
Thank you so much, Martha. Tom, do you mind introducing yourself?
Yeah, absolutely. Thanks, Alan. So Tom Meixner, I'm at Healthfirst. I've been in the industry for over 30 years, all on the payer side. I grew up at Horizon Blue Cross Blue Shield, spent many of my years there in the actuarial department, had a brief stint at United Healthcare, and I've been at Healthfirst for about 11 and a half years now in a variety of different roles. currently running our network of community physicians, along with innovation within our risk model and delivery system. I would say that, I've always, the roles I've been in, I always work closely with our providers on keeping our risk model relevant and ensuring that I'm working with our providers to actually improve performance. A little bit about Healthfirst, and we'll get into it later, but over 1.6 million members, and what's mostly in the Medicaid space or the low income space, large population with Medicare Advantage also. And my apologies, sorry, I get put on camera and all of a sudden I freeze up. What's unique about Healthfirst is that it's an extremely large value-based risk transfer model. So over 80% of our membership runs through a total cost of care model. So it's very different than your traditional plan in that it's just, it's all about risk transfer model. It's not your traditional NCI. So thank you.
Thank you so much, Tom. Really appreciate it. And Dr. Mohanty?
Hi, thank you, Alan, and good afternoon to everyone. So I'm Sarita Mohanty. I'm with Kaiser Permanente. I serve as our Vice President for Care Coordination for our Medicaid and vulnerable populations. And as Alan mentioned, really focus on aspects related to whole person care, care coordination, case management, and including the social determinants of health across our enterprise. I have been with Kaiser Permanente a little bit close to 6.5 years. Initially, I started in the Northern California region, and then I went to the National Enterprise Program to focus on enterprise solutions. And when I talk about enterprise, it's really about how do we standardize and optimize our approaches around care coordination across the continuum. Again, looking at whole person care, the comprehensive social, physical, behavioral aspects of care, and really trying to learn from one another and as an organization and implement collectively as well. Just a little bit, and also by background, I'm an internal medicine physician, and I do some practice in the Oakland area at Kaiser Permanente. A little bit about Kaiser Permanente. We are one of the largest. We are the largest integrated not-for-profit healthcare systems in the country, including health plan, hospital, and our Permanente Medical Group. We reside in 8 states and the District of Columbia, and we serve over 12.4 million members. And we also like to call out that includes also the 68 million individuals in the geographies in which we reside. Because one of our missions at Kaiser Permanente, we really exist to provide affordable, high quality healthcare services to improve the health of our members, but also the communities we serve. So with that, I'm really excited about today's panel, and thank you for the opportunity.
Thank you so much, Sarita, and thank you all for joining. And for those of you who are guests, appreciate you being here. So we'll start with a high-level question. We'll drill in as we go. Maybe just if each of you could talk about, really from your perspective, your where you live, your own organization, but also feel free to talk, I think, big picture. Folks are interested in understanding, when you look at health plans today, your plans and what you're seeing with other plans, how are they responding to the COVID-19 crisis, which clearly we're not in any kind of post-COVID world today, right? It's still going forward. It seems to be on the uptick again, which we're learning recently, right? So if you think about your short-term strategies going forward that you're taking at this point, and then your long-term strategy, maybe help us understand what your thoughts are on that. What are some of the key critical success factors you see plans taking into account? And so if it's okay, I'll start with this actually with Tom. Tom, can we ask you to give some thoughts on this, and then we'll hand over to Sarita.
Yeah, absolutely, Alan. Thank you. So I'll break it down into member impact and provider impact. And let me start with the short term. Short term on the member side, I mean, the good news is we were already focused on our digital strategy long before COVID hit. But obviously with, the impact of COVID and the need to connect with members virtually, it really did accelerate, the need to really beef up some efforts there. So good news was we were planning for it, but it really has just made us double and triple down on our digital strategy with regard to connecting with our members virtually. I would also say from a short-term perspective, issues like food insecurities have gotten significantly worse with the impact of COVID. So coupling that with, some analytics where we kind of figured out, who are the members that are most in need of it, and the digital strategy around how do we connect with them. We did a lot to make sure that we're doing everything we can to connect our members to organizations like NowPow, et cetera, that we work with in order to help them, get the help that they need. Also short-term from a member perspective, we just did basic things to keep, things you could do to keep the member safe by extending supplies for, prescriptions, DME, et cetera, anything you do to kind of keep the member home, keep them safe. Short-term, shifting to a provider perspective, I think one of the things that we focused on a lot is cash flow for providers. In our model, where it's essentially a risk transfer model, the money will eventually come back to the delivery system, but it isn't always quick enough. So we spent a lot of time really focusing on cash flow and making sure that the providers actually had everything they need in order to sustain during these times. What I would also say short-term from a provider perspective, telemedicine. I mean, I think what as bad as COVID was, I think one of the things that it did is accelerated the efforts around telemedicine that took the industry many years to get nowhere with. So, did a lot to make sure that, our providers actually have telemedicine capabilities and our members can connect to them. So focused a lot of short-term energy on that. COVID actually accelerated that significantly. And then lastly, from a short-term perspective with the providers, we focus on, as all plans do, we focus on quality. Quality is extremely important. It's a strange year to kind of deal with, a lot of the quality metrics that we're always, chasing after. So we had to, shift around a little bit our thinking in our quality program that we work with our providers on, making sure that it's reflective of what they can do in these times. And we had to be really flexible with how we work with them, because some of the normal approaches that we take on working with our providers to just, send a list in a normal time may not work the way it does, in COVID time. So, short-term flexibility on making sure that we're doing everything we can to work with our providers to help them move the needle on a quality perspective. From a longer-term perspective, I would say, we are a value-based plan, but I think we're looking at, are there areas where we could expand, and are there more providers that would serve, be better served in a value-based model, and trying to figure out where that fits within what we need to do. And then lastly, I would just say that, I think our clinical team is really focused on the long-term impact of COVID on the members. I mean, I think with everything that's going on and the tougher for people to get services right now and what the potential impacts are from COVID, our clinical team is just really focused on making sure that, we're treating our members in a way that, the long-term impact is not, ultra damaging, to their healthcare needs. And then I also say, just to kind of tie it back a little bit to the short term, I think longer term, we're trying to figure out what the right telemedicine reimbursement strategy is. I mean, I think because we want to make sure that we're paying the right amount so that it's actually relevant to our providers, but not overpaying where it's inappropriate. So I think, it's a kind of a tie between short term and long term, but, I do think there's a place for telemedicine moving forward. And I think it's really important that we reimburse in a way that it doesn't become obsolete.
Thank you, Tom. That's fantastic. Really appreciate the insights. Dr. Mohanty, can you talk a bit about what you're seeing?
Yeah, I think a lot of what Tom mentioned definitely intersects with some of the things that we're seeing at our organization and in our communities. We are, as I mentioned, an integrated system, both health plan as well as provider hospital network. So, we have seen across the footprint of our integrated model that the pandemic has essentially transformed our landscape as we've seen it. And, we have become, as an organization, we've had to work to become much more nimble, much more innovative, more focused on, and how do we shift even to more home-based care in ways we haven't thought of before. Some of the things, as we think about disaster preparedness, I mean, certainly, like, all organizations, coming together to form national and regional command centers that bring together the health plan and the medical groups, and we leverage a lot of experience that, for example, we had to deal with the fires in California to really kind of quickly bring forth that infrastructure to address the COVID pandemic. And as those command centers continue to be fully operational and are pivoting at any moment for any urgent needs or emergent needs that are arising for our members and our employees as well. I think we're really looking at, of course, telehealth, and we've, we are seeing up to 90% of our visits are virtual. As somebody who's an internal medicine physician, I conduct both video and telephone visits, I can see that, there is a lot of high satisfaction with the experience by our patients. And they don't have to deal with parking, they don't have to sit in the waiting rooms. So we're really trying to, I think, short term, obviously keep, we've really accelerated a lot of the technology and the capabilities so individuals can get the access they need and they understand how to use video visits and they're oriented, et cetera. At the same time, we got to make sure, I think long term, that they're not avoiding or, foregoing preventative services or important, so we're trying to do outreach and, more, we are prioritizing needs of people coming into the clinics when needed for those type of in-person evaluations. So I think, and I would say like long-term, what we're trying to do is as a health system, as a plan, as a provider, we really do we're working on how do we achieve the right balance, the ratio of virtual care with home care, with in-clinic care. And I think that's going to help all of us, get to the point of, seamless care and important coordination of care. And so the other things I think I will just say kind of long-term, I think short-term, I think a lot of what Tom said we're working on. I think long-term, we are recognizing that telehealth is more than the video visit. And, how do you start to use the telehealth framework model to engage the whole care team, the family, translation service, primary care providers, the social worker. And so that's something that we've been working on to expand that and use a lot more digital capabilities to help us. So using the chat bots for members and non-members to address their COVID symptoms, doing assessments and identifying somebody who's low, medium, and high and getting them to the right points of care. So I think these are some of the things, I think social determinants of health, and we'll talk more about that, especially as we see more people having moved to government programs and having disproportionate social needs, another key area. And then the last two things I will just say is healthcare workforce. We really had to think about how we rethink our workforce and facility models to support the new reality. How do we, think about the multiple layers of middlemen, both in administrative area and also the care settings, and reevaluating supply chains, like how do we really augment mail order pharmacy, DME delivery, as Tom mentioned. And then the last thing I'd say is making sure that all the work we do has a quality and a health equity lens to our work. So.
That's fantastic. So Martha, they took a lot of the good ones, but anything to add from you?
Yeah, they certainly did. I mean, the nice thing about what's happening is that, the adage, never let a good crisis go to waste. I think what you're hearing is the industry really pounced on the crisis to make things better for the future is how I would describe it. So, I mean, a lot of what we did was really focus on a lot of the same things that Sarita and Tom spoke about. On the telemedicine front, it was actually really, very interesting. The regulators took action, right? I mean, one of the things that we have to really recognize is that both CMS and the state very quickly took action to loosen up restrictions that were really prohibiting us from advancing things like telemedicine, especially for vulnerable communities. Our Medi-Cal population as an example. A lot of the service that is provided to the Medi-Cal membership in the state of California is provided by federally qualified healthcare centers. And they, quite frankly, unless they saw somebody in their four walls, their model was not reimbursed. And so regulations were really hampering our ability to expand the use of telemedicine for vulnerable populations. And the good thing is that in a matter of weeks, which is really unheard of when you think about all of the restrictions and regulatory hurdles that plans have to overcome, we were able to stand up telemedicine capabilities for our 2 million members on the Medi-Cal side and 3 million members across all books of business in just a matter of weeks. And part of that, we knew that we needed to do our part to support our partner hospitals. Many of the hospitals had pivoted very quickly to trying to figure out how to add capacity for potential surges that were coming up. And so we were trying to do everything in our own power to avoid the unnecessary use of hospital services, believing that that was the right thing to do to leverage the capacity for COVID patients potentially. And as you can imagine, we came across all kinds of barriers, technological, employee bandwidth issues. I mean, just like many of you, we had to very quickly pivot to having a fully remote workforce. And in the midst of all of that, our people were working double duty to stand up the capabilities. At the same time, what was happening is, providers were very nervous. One of the things that they were very fearful of is that health plans would pivot to using vendor solutions to support the telehealth capability and that access to care, and that, their practices would be hard hit in that process. And so what we also did in parallel is supported many of our provider practices to really fully embrace and be telehealth enabled. We invested $13.4 million up and down the state in basically helping provide everything from technical assistance to software to hardware support for about 140 organizations and 138 grantees. And they very quickly pivoted and stood up telehealth capabilities. And our primary goal there was A, provide access, but B, we wanted to make sure that long-term we did our part to be sure that our members maintain continuity of care with their primary care providers. And at the same time, on our mental health network, same thing, we quickly pivoted to getting our behavioral health providers up and running through telehealth capabilities. And just a quick stat to give you a sense of the magnitude of the impact that had been made. For our behavioral health network, on any given month before COVID, we were seeing 500 telehealth behavioral health visits. After, it's closer to 70,000 in a given month. So, I mean, the magnitude of change here has been dramatic. And, as all of that was happening, the member outreach that Tom talked about was critically important. We knew that there were people out there that were very nervous, very anxious, fearful of accessing the healthcare system. So we really geared up and did quite a bit of outreach to especially high-risk populations. And then in our model, because it's not a fully integrated model like Kaiser, we do depend on a number of network partners, provider partners, hospitals, nursing facilities, and the like. So we really had to amp up our game in terms of, communication daily, real time, to do our part in facilitating prompt and safe discharges. And in some pockets, right, what happened depending on the period of time, they got more hard hit than others. So I'll give you a couple of examples. In Imperial County, Southern California, and then the Central Valley, those two areas at different parts of the pandemic got very heavily impacted. And so we had to do everything we could to help support those hospitals transition members to other parts of the state, help support them with getting basics like, PPE into their hands to do, to serve members well, et cetera. The issues around food insecurity, I mean, that can't be understated. There was some serious issues, and doing things like working with food banks and Feeding America or providers to give them gift cards to give to members to go out there and get needs addressed was critically important. And then just longer term, we're very pleased by what has happened with the behavioral health access and availability and transition there, as well as telehealth. So, similar to what Sarita said, we're trying to focus on how to make sure we're much more intentional about leveraging telehealth, the right time, the right place for the right reasons, continuing to make behavioral health access continue to expand. It's critically important. And, doing so in such a way where we're reaching many of our underserved communities. If you could just imagine, we serve urban areas, we serve rural areas. In the urban areas, their challenges are different than in the urban areas. In the urban areas, we had to struggle and continue to struggle with things as, basic internet connectivity to enable that telehealth visit. So There's much more we've got to do, but we believe that the foundation that's been set during this, the last several months have been really, really helpful to expanding access and doing the right thing for the future.
Martha, thank you so much. That was really great. And if it's okay, I'm going to stick with you for a minute because I think it's a nice segue, particularly with you personally, your expertise and Healthnet's reputation expertise. Are you seeing increase in demand or different demands from providers, physician groups, and others with relation to risks? Or are you seeing any different behavior on the other side of the table with relation to the desire for risk contracts, how they want risk contracts to run? Are you planning on offering different modalities in the future? Can you talk a bit about kind of what you're saying there?
Sure. So, one important thing to know about Healthnet is that for decades, Healthnet has really been on the forefront of risk-based contracting, working with provider organizations to, where they were ready, help them assume managing populations holistically, capitating them and allowing them to assume varying levels of risk. I mean, in fact, something like 79% of our professional spend today is capitated with some level of risk sharing. So we do continue to see a level of appetite for that. I think initially there was a swift reaction on the part of many in the industry to see capitation as the answer to things like the pandemic, because as demand for visits dropped dramatically early on in the pandemic. I mean, providers were reporting that they were only seeing 20% of their volume. For our network in particular, there were actually there was some level of safeguard against financial hits for the provider community because of the way that we contract and because of the fact that we capitate. With that said, I will say that there continues to be interest in risk in parts of the state where they hadn't historically been interested. We are getting, as an example, more demand for capitation and value-based contracts in rural parts of the state where, perhaps in the past that wasn't necessarily there. For us, capitation, value-based contracting, risk models have been part of who we've been and is a central part of who we will be going forward. I think the trick is we've also seen over time that not all providers are really well equipped to manage risk at extensive levels. So it's a bit of a phased process that providers need to go through to get to a state where they're really equipped to assume the financial risks. So to answer your question, yes, we've seen appetite continue to increase. It's part of our fabric and our being, and it will continue to be going forward.
No, that's great. Thank you. And maybe Tom, for a perspective on the other side of the country from another plan that has also been in VBP, what are you seeing and what are you all doing based on changes in demand? And honestly, of course, as Martha said, changes you're seeing in the market and what providers can and can't do.
It's a great question, Alan. And I'd say I'm going to answer the question about what we're seeing in the market, but it's not related to COVID. So that we've seen this trend that started before COVID, but we are a hospital sponsor plan, and our risk model was built with our sponsor hospitals. So we're often viewed as a plan that shares risk with hospitals and doesn't do as much with community physicians. We actually do a lot of value-based contracts with our community physicians as well. And I would say the trend that we've been seeing in the market is that community-based physician groups are getting more organized and are looking to take on more risk, which I think is a great thing because I think they're equipped to do so. They're close to the patient. What the challenge for us is to strike the right balance because, with so much already running through a total cost of care model, it's trying to figure out how to strike the right balance between the risk that you share with the physician group and our sponsor hospitals. So what we've been trying to do to address that is I think the value-based deal works best when all parties are aligned, meaning the health plan, the hospital system, and the physician groups. So we've been, looking for opportunities where physician groups are getting organized to kind of figure out a way to get them more into risk in a way that they're partnering with the hospitals. So it's not a threat to the hospitals that are losing risk. It's more, as they work together, you can kind of improve overall outcomes, efficiency, and then there's more to go around for everybody. So, I mean, that's the trend that we've seen over the past couple of years that's really front and center for us. What I would also say, though, the thing that concerns me about, the impact of COVID, everybody loves risk when you're making money. People don't like risk quite as much when there's not a lot of money there. And I know we'll probably talk about it in some of the other questions, but the state budget issues in New York were there before the impact of COVID, and now with lower tax revenues and more Medicaid members, it's going to be accelerated. So, we're just working closely with our regulators to make sure that there's appropriate funding for the program, so that, to me, value-based contracts are the right way to go. It creates the right incentives. It creates the right, if done right, you build the right relationship between the plan and the provider, so it's not adversarial. The risk that COVID presents is that if this damages the state budget situation really badly, they need to continue to fund the program adequately so that people actually want to take on risk contracts, because without that, it just becomes a game of denying and fighting between the plans and the MCOs and plans and the providers, which is never a good thing. So I think that's the longer term concern that we're focused on. But yeah, I think, the trend in the physician space is really what we've seen more recently and what we've been trying to react to.
Thank you, Tom. It's super helpful. And it's a good segue because, so Dr. Mohanty, if you think about other market trends, right, that are driving strategy, and clearly some of those themselves, as Tom mentioned, things like state budget cuts are partially COVID-driven, of course, maybe some would say majority COVID-driven. But what are some of the other major trends you're seeing that are driving strategy in the next 3 to 5 years, as well as any near-term tactics, that may not be COVID-specific, whether related or not?
Yeah, thank you. I think it's a really important question. And, we are seeing a lot of, in COVID, we saw a lot of market trends emerging, but COVID really did accelerate the thinking and the process and the action that we needed to take as organizations taking care of patients and communities. So, I think one of the things that has really been a focus is how do we start to make our care less fragmented, and because right now the experiences of patient, clinician, health system, and payer goals, we have to align those, and including how we engage with our patients between episodes. So digital end-to-end digital capabilities has become a real focus to really allow for that personalized experience. That can be optimized across across all our goals, whether we're a provider or a payer or a patient, right? And that really then allows us to, improve the population health in the way we seek to achieve. And like examples being, and I think we're seeing this, like how do we streamline a facility's experience to be zero contact, virtual waiting rooms, as an example. How do we address what a lot of people are describing as sometimes the invisible epidemic, like mental health, social isolation, the fatigue, substance use disorders. So how do we do that? So the digital aspect, I think, is one of the major market trends that has started, will continue to evolve over the coming 3-5 years. But we're doing a lot of work in our own organization to do that. We have a member-facing tool, which we call kp.org. And, to be perfectly frank, it has a lot of capabilities and the ability to, do things on behalf of yourself. But now we're taking it to the next level. And that includes how do we start to use artificial intelligence and machine learning as we see more digitalizing of services. We're going to get more data, and how do we incorporate that into the future of AI and healthcare? So, and how will that lead to better documentation? So how does that data that translates to better artificial intelligence lead to better documentation, automated coding, provider coaching, and even clinical decision support? and a lot around screening, whether it's behavioral health and social health. So these are some emerging trends that definitely we're seeing. I think with chronic care management, which is one area of focus for me, via virtual care, which is where we've moved and will continue to, that won't go away, offering more small, frequent touch points to provide kind of that consistent support and better outcomes than just the kind of infrequent longer visits. And we'll have more capability with the virtual the technology to do that. Things around home delivery services is another area. Again, I talked about supply chain earlier. How do we get more oriented towards the patient's home, prescription delivery, DME? And then the passive remote monitoring is another example of, especially for those who may not be as have the capabilities they need. So how do we support them with those capabilities? And one example is last month, the Kaiser Permanente announced an effort with Best Buy Health. And we did a pilot program in 2019, leveraging technology and support services through remote monitoring tool, which is called Lively Mobile Plus, starting with our employees. And it's basically like a two-way communication device that provides in-home or mobile care. Users can press a button to connect with individuals trained to triage like emergency and non-emergency situations, can help seniors in instances if they're having car trouble, being locked out of their home, experience a medical emergency. And so it has that emergency response system, et cetera. And on October 5th, the partners, our partners with Best Buy Health and us rolled Lively Mobile Plus out to all Kaiser Permanente Medicare members as part of a Medicare Affinity program. So these are again, providing non-medical products and services to help older adults and live independently at home. So these are things that we're going to see. Again, I guess that balance of virtual versus home care versus clinical, in-person care. How do we achieve that balance? So I would say that's the trend. I think one last thing I'll just say, and then I'll stop, is that, I think one thing that has come up a lot and just kind of separate, a little bit different from what I was describing, is around the value of Medicare, Medicaid integration. I want to focus on the government programs. As an example, we're seeing that our models are extremely complex and varied, especially when you're having to navigate two large and quite disparate systems. There was a report that recently found that there are at least 43 combinations of Medicare and Medicaid coverage nationwide that constitute a dual experience, and you can see the experience is quite varied. So I think that these are another things that we have to think about: integration of products and how do we, again, it gets back to that seamless care approach that may be lacking in these instances.
I thought that was really great, very specific. So maybe to stay on that for a moment, just taking a layer down, not that I actually didn't go all the way down to the member, but if you think about the fact that a lot of these members, as you said, there's this move to Medicaid in terms of this, being in California, right, large unemployment. We haven't seen the Medi-Cal pick up necessarily early on as fast as we thought, but it's picking up, right? We're certainly expecting more Medi-Cal pickup, and then Medicaid across the country. So how do you see non-traditional organizations? So if you think about a network of doctors and home health and DME, right, hospitals, those other pieces, but now you've got the food pantry, you've got transportation, particularly like a dial-a-ride, right, for the disabled folks, a whole variety of different types of organizations, and for that matter, services that you may not today pay physicians for. I know the Kaiser model being, of course, a little bit different, but what is your thought on how you're integrating those community-based organizations, if at all, and non-medical care into your model, and how are you paying for it?
Yeah, it's a really important question that I think all of us are working on, and I think we've all recognized, kind of how the COVID-19 pandemic really did kind of underscore what we already knew, that being healthy is not just about high quality medical care. So we really did strive to think about how do we address one's basic social needs, such as again, social isolation, having social relationships, balanced meals, safe housing, reliable transportation. And, we felt as a healthcare system, and I think most do, that we have some responsibility to care for, to identify ways to care for members our patients' social needs in addition to their physical and mental health. So I would say some of the things we've done, we have really created a framework around how do we effectively identify, connect, and support and follow up on individuals with social needs. And so I will speak to something that I have been working on for the last couple of years, which we call Thrive Local. We launched this in 2019, and this is with a partnership with a technology vendor, Unite Us, where we're creating an enterprise, we have an enterprise online phone book or directory of social service community-based resources. And we've actually taken it one step further to not just have the directory, but also have the ability to make social referrals through the platform to those agencies that can support finding employment, housing, et cetera. And so in COVID, we did a lot, we had to accelerate a lot of that. We felt compelled. So we launched our resource directories much faster than we anticipated or planned because of the emerging needs, especially emergency food, emergency housing. We've made everybody in our organization have access to the link to that resource directory. So they have a web link. We've also integrated in most of our instances in our Epic EHR so that you can access it through the EHR and not have to go outside of the electronic health record. We have actually, worked with, we created a member-facing call center. So not only do providers have access to the tool and can help members or patients, but a member can also call a call center and get help for those social services, get connected. The agents are actually looking up services in the Thrive Local Unite Us platform. So, I mean, these are some of the things. Now, it gets to your question about, like, how do we do this effectively, knowing we're not necessarily paying for these services? I mean, these community-based organizations have varying ways of being funded, supported. And I think this is something that we are working on. I think certainly we're seeing, like in California, there is going to be, ask of plans to start to incent or pay for services in the community space in lieu of services. For example, that, the CalAIM proposal in California, for example, for Medi-Cal stipulates. And so we want to build these relationships, have data to understand what are the gaps. As you're referring people to services, it doesn't mean that every agency is going to be able to accept those referrals. So then and having that data, which we didn't have before, to say, okay, and when I say we, collectively, not just Kaiser Permanente, but all the payers, providers in the community, to say, how do we then lift up those services that are going to be so critical to the needs of our patients, right? So I think that is something that we are actively working on because a lot of these services are not benefited and services at this time. But we're going to start to see that by connecting people to social service resources, we're going to see impacts on quality care. We're going to see potentially reductions in avoidable high-cost services. I think we can all hypothesize that. Not a lot of data out there, but we are certainly trying to build those tracking and evaluation to understand that. So I think we have a lot ahead of us in this journey as organizations, and that's what we're working on right now as one example. But we're also working on screening and a lot of care coordination, case management. How do we leverage community health workers, et cetera? So I'll stop there, but hopefully that answered the question, Alan.
No, thank you so much, Sarita. And I think I'll pivot to Martha with the same question, because you mentioned, Sarita, California with the CalAIM and, of course, reprocurement coming soon. So, Martha, from your perspective, not being in the Kaiser, a vertical network per se, what have you all seen? What are you all focusing on with relation to these non-medical services and non-traditional providers?
Yeah, so, that's a great question. I mean, I think, the question you asked about how to pay for it, I think that's something that we're all trying to sort through. Current state, CalAIM does bring a lot of promise. The idea that we'd be able to invest in lieu of services and think about things more holistically and in a person-centered way. Where I think many of us are really very excited about that. The way that we've approached things over the last several years to really gear up for that day when we have figured out the financing mechanisms within the state is we've really leaned into our partnerships at a local level. You know, whether it's partnerships with federally qualified healthcare centers, with community-based organizations, or with county partners, you know, whether it's the Department of Health Services at some of these counties, mental health agencies at some of these counties, et cetera. And so we've done a lot of testing, a lot of piloting of different models of care. We've learned a lot in that process. You know, the idea that screening is critically important, you know, I couldn't agree with more. The data and the analytics, data exchange, you know, really thinking about the continuum of care outside of strictly a physician office is really an area that we've been very hyper-focused on. And so that all is going to require a significant level of investment that we've begun to make and that we will continue. But the way that we've looked at it is really time for us to pilot new and innovative models with promise so we could learn. And so some of the things that we have in fact learned from some of the investments that we've made in some of these partners, quite frankly, through grants that we've issued, is, you know, number one, workforce is critically important. There is talent across the ecosystem, whether it's in the healthcare space, within the nonprofit sector, counties, and otherwise, that if they have the right level of skill, they will be able to support the needs of our community, our members, our patients much better than we have in the past. So upskilling the workforce is important and something that we think is going to need to be front and center. Pipelines, right? So getting into the high school system, the community college system, colleges, to really encourage, especially, you know, people of color to get into the healthcare space or in the surrounding ecosystem to support the needs of members is really going to be important, or we're not going to have the workforce we need to do the right job. And we've got to make sure that we do everything that we can to get out of the way of the clinicians so that they could really focus on the clinical work. And, you know, around that, we can wrap them around with the supportive services to get at some of these social issues that are, you know, barriers, quite frankly, and, you know, a healthier way of being. So, you know, it's really a multifaceted approach that we've been taking. And we recognize that in some cases, it's really about, you know, even looking at things in 2 generations, right? So how can we support a mother living in poverty, raising children early on to get that person, that child, at a better state when they're, you know, in charge of their own health and well-being. So it's really early intervention. It's everything around embracing some of the very good work that has been set for us through the state's priority, the focus on adverse childhood events and understanding and screening and equipping our provider workforce to really deal with the issues that are surfacing as they're doing the screenings related to that. So investments, piloting, understanding, testing, iterating. We think that all of that is really helping us to think about how to deliver the value that the CalAIM objectives promise to bring. And as we go into reprocurement, that's really definitely front and center for us.
Great. So, Tom, you're not in California, obviously, so you bring a different perspective. So same question in terms of, you know, you talked a bit about actually early on the need to reach out to folks who are having food insecurity, for instance. That was one of your early points. So when you think about some of the other areas that are not traditional medical areas and how you all, with your risk agreements today, would migrate into a place where you might integrate those differently or pay for those differently, what all are you thinking out there in New York?
Yeah, so thanks, Alan. So, I mean, some of what I would say is very similar to what Martha and Sarita said, so I'm not going to repeat everything they said. I mean, I think issues with social determinants of health are just so critical. They cause such disparities in health equity, and it's just going to be, you know, so much worse now with you know, the impact of COVID on the economy. So what I will say, talk a little bit about some specific things some specific pilots that we're working on that kind of ties together a lot of the things that both Martha and Sarita said on, like, you know, how you bring data together and how you pay. I mean, as I'm assuming it's the same all over, but the CBOs are paid through grants right now. They don't get paid directly. So, they can see so many people, but it's kind of, they're kind of outside of the healthcare ecosystem. So one of the things that we're trying, there was both people mentioned analytics and the need for that. And Alan, I'll give the ARC Analytics platform a plug here too. As there's a module in there where you could bring in data on social determinants of health. So we're actually in active discussions with a couple of our partners about a pilot where we would actually contract directly with some of the CBOs and pay for it out of some of the surplus that's earned by the risk pools, and do it in a way where we're actually bringing in analytics as well. So, we may have 2,000 people that have food insecurities, but you may have 200 that have, diabetes and other comorbidities that if you prioritize them first, you can have a much bigger impact on, overall, medical costs and patient outcomes and whatnot. So, I'm not going to repeat everything they said, but that's a pilot that we're excited about, where we have some of our sponsor hospitals that are actually, they're willing to let us pay for the CBO services directly out of the risk pool. We just have to figure out, how do we build those contracts? Even figure out a way to incorporate value-based metrics into those contracts with the CBOs as well. So a lot to figure out, but I think, we have a couple active discussions about that we're excited about, which we think could maybe, because it seems to feel like, doing more with the CBOs can have a significant impact, but nobody's actually proved it out yet. So, I think we're going to try it in a way that it's not like, investing all of our time, but in a way that we can kind of do it in a big enough way to see if there's an impact. And if it works, then figure out how to kind of double down and spread that across most of our population.
No, thank you so much, Tom. All of you, really specific, helpful feedback from all of you that I hope you're enjoying. I know we have about 8 minutes left, so maybe I'll ask a question and we'll see if we have time at the end of it. But I think one of the things folks would love to hear, especially from you three who've got so much experience between you, but also are so deep into this right now, if there were 3 or 4 things that you personally or your organization learned from this whole COVID experience that you wish you'd learned earlier and that you wish other people understood, any lessons learned, might be more tactical, that might be things we haven't discussed, that were just really important, kind of aha moments that you pivoted on. Can I ask you, Martha, just any examples that we haven't talked about of specific lessons learned that folks should keep in mind on the go forward?
Yeah, so I would say one of the lessons is really, it's critically important, that we get out there and communicate with our partners early and frequently. Things, especially, during the pandemic, things were moving very, very quickly. And as we were doing our own planning, it was really important for us to have line of sight to what was happening around us. And so, initially, I would say some of our providers probably felt a little bombarded because we weren't the only ones out there asking questions. And so, one of the things that we do recognize is that in cases like this, associations have a really critically important role to aggregate the insights, get a good feel for what's happening and getting the lay of the land, so that then plans can kind of tap into that. So I think, a big learning for us is whether it's, doing what we did in terms of communicating for facilitating discharges, whether it was, working on issues that are affecting our workforce and getting them to work more remotely from home, or whether it was communicating with members. If you could just imagine a few hubs and spoke, visuals, communication is critical, but if it's not organized, it can create chaos. And so, much like, I think before the panel started, Tom was talking a little bit about the weekly sessions that his plan is having with their entire staff. Similarly, Healthnet, one of the things that we've done is we have weekly Monday afternoon sessions with our supervisors and above, because things were shifting so quickly, because in order for us to get out in front of our workforce, we had to keep things moving and doing it real time. It's the same thing with the provider community, same thing with the regulators. Just think about all the stakeholders that had to really pull together to make things work. In some of our counties, we had cross-plan ongoing weekly discussions to talk about things like testing and PPE and everything else that was important. So I would say lesson learned was the importance of organized, orchestrated communication channels to avoid chaos and killing people in the process, because we're tapping into all of them all at the same time.
Tom, what's your take on that? What are the key lessons learned for you in this experience?
Yeah, it's a great question, Alan. I mean, I would say first, as a plan, I think we're extremely proud of how we handled the transition to COVID. I mean, we had to pivot on a dime, get all our employees working from home, work closely with our providers to make sure that they had whatever they need to treat our members and their patients. So, I mean, a lot of great things. I guess if I had to call out two things that I think that the pandemic kind of alerted us to, or at least alerted me to in the role that I'm in, is the first I would actually almost term preventive contracting. I mean, I think, we're now looking at certain things that we pay for COVID tests that we didn't contemplate beforehand, that, you're like, wait, well, we're paying for this amount for somebody to just walk in and get a nose swab and walk out 5 minutes later, things that we never even thought about. So I think, to me, one of the lessons learned is, like, we don't know what we could be faced with moving forward. So how do we think about, what tomorrow's crisis could be? And when we contract, make sure that we're paying appropriately for the right services, but not overpaying for services that, we didn't even think about before this happened. And then the other thing is not rocket science, but just the need for continued agility and flexibility. I mean, so, when Martha was talking, she was talking about like some of the stand-up groups. We did the same thing. We had stand-up groups to deal with, this, that, the other thing, and they were great at the time, right? We everybody was shifting to home, from working in person to work from home. They had to stay connected. You look in 3 months later, some of those forums that you stood up are no longer relevant. So I think it's just the continued agility, like, how do we make sure that we're actually discussing the right things? And, something may work quickly, but it may no longer work 3 months down the road. So I think just continuing to evaluate what we do and why we do it, and making sure that it's still, I mean, the world's changing drastically almost every day. So, just looking at things from a critical perspective and saying, look, we want to double down on this, but we want to stop doing this because it was great 3 months ago, but it no longer exists. So nothing earth shattering there, but those are the two things I would say are like my main takeaways from this crisis.
No, really helpful. I love that preventive contracting one. That's the first time I've heard that. Makes a lot of sense. So Dr. Mohanty, I think we're going to give you the last word. Lessons learned.
Yeah, no, I mean, I think both my co-panelists here, Tom and Martha, highlighted, I think what I had on the top of my list, I'll just reiterate, is communication. There's no such thing as over communication, and especially when you're trying to move things quickly and provide clarity on your approach as you go forward. And when I talk about, I think we did a really great job as an organization. We're as an integrated system to communicate amongst ourselves. Where I think we had, think if I were to, think even more, where we can always do better is even how do we communicate externally to our community partners, to the trade organizations that Martha mentioned. I mean, just really making sure that there is clarity on what we're all trying to do. And actually, I think one thing we did do well that I would even continue to support and recommend is sharing what we've done. We created, like, for example, COVID playbooks. We have a clinical playbook and we have a social health playbook, and we've recently shared that externally as well. So these are kind of things that I think as organizations, we have a commitment, in this landscape to share what we're learning from one in our own organizations, and how we can make it more scalable across the communities as a whole. So I think I would say that, and I think the last thing I would just say that we could have probably recognized sooner is the gaps in digital literacy around, when we think about telehealth and all the things. I think there are still significant gaps, particularly in like Medicaid and low-income populations. So we are, as we're being forced into a more virtual visit model, so some opportunities there that we will continue to work towards.
Thank you, Martha, Tom, Dr. Mohanty. I personally feel extremely lucky. Having this hour to get these insights was really, really incredibly rich and deeply appreciated. You all are super busy. You're running organizations critical to the health of our communities. I think everyone on the phone would like to thank you. I know some of the folks on the phone deeply appreciate what you all do, because I know who they are and how much they appreciate you. So I just want to say thank you to all of you. Thank you to the folks who are joining us. We'll certainly get the information out to folks after this, but want to be respectful of folks' time and end on time. So again, thank you. And Alice, we'll say good night. Everyone stay safe.